Okay, so we'll now talk about plasma proteins. Um, and remember, for us to come up with proteins, we start off with your amino acids. And remember, for amino acids, we talk about essential versus non-essential amino acids, right? You do remember from your biochemistry that we essentially have about 20 amino acids, and of those 20, some of them were essential, then some of them were non-essential. Those that were essential, those are the ones that cannot be synthesized by an organism, and you need them in diet, right? So those include tryptophan, leucine, lysine, histidine, to mention a few. Then your non-essential amino acids are now things like glycine, glutamine, proline, serine, to mention a few, right? If you remember that basic, you just need it for an understanding, right? And basically, proteins, we need them in the body because they're more or less the building blocks that you have for certain tissues in the body, right? And most of the proteins, they're going to be produced by the liver, with the exception of other proteins, for example, the gamma globulins, which come from the B cells and the plasma cells, which are responsible for this. And when we take blood samples, remember we talk of plasma, Buffy-Coat, as well as your hematocrit. Right? So when you centrifuge, the hematocrit takes up about 45%. The sediment below. Then you have a Buffy-Coat about 1%, where we have the white blood cells and to some extent the platelets. Then we are left with the plasma, right? Plasma will be more or less about 93% water. And when it's 93% or 91% water, the remaining will be the solids. Of those solids, we have an inorganic component, almost 1%, then an organic component, is about 8%, right? Then your plasma without clotting factors, which is now the fibrinogen, the prothrombin. Remember the clotting factors that you need for the coagulation cascade. Your plasma without those clotting factors then becomes serum, right? So about 55 to 60% of your blood volume is actually what we call plasma, whereas the hematocrit is about 40 to 45%. That's what you then focus more on when you do your hematology, right? So what makes up these plasma proteins? We think about the clotting factors, mainly fibrinogen. We'll think about other proteins like globulins, which you divide into alpha globulins, beta globulins. The alpha one, there's alpha 1 and alpha 2, then gamma globulins, your immunoglobulins, which are responsible for immunity. Right. Then we talk about albumin, which is the most abundant protein, to mention a few. Right. So for these proteins, specifically albumin, you need to be able to know the normal values. Right. So the normal values for albumin will be around 3.5 to 5 grams per DL, and total body protein, or plasma protein rather, should be between 6 to 8 grams per 100 mils, right? So now when you see changes, let's signify some form of pathology, maybe in the liver, but remember I said the liver produces most of the proteins. But when you see a decrease in the gamma globulins and increase, this signifies problems with plasma cells or your B cells, right? So in simple, you need to carry your basic biochemistry and your basic physiology to such a discussion on plasma proteins, because it guides you or it helps you to better understand like what you really need to understand, right? So what are the functions of proteins? For pathology's sake, I'll talk about oncotic pressure more. We've been talking about oncotic pressure quite a lot, coming from Starling's forces, where the net flow out of fluid out of a vessel rather, is the hydrostatic pressure of the fluid within the vessel minus the oncotic pressure of the fluid within that blood vessel minus the hydrostatic pressure within the tissue, right? And that oncotic pressure, if we're saying we're subtracting it, if the oncotic pressure becomes less and less and less, the value for the net flow out becomes increased, such that you can get an edema. This explains why you look at people with kwashiorkor, they present with a distended belly. That distension is not because they are full, but it is simply because of changes in fluid balance. If you look at babies that are malnourished, we talk about NOSAM and OSAM. NOSAM is non-edematous, severe acute malnutrition. OSAM is edematous, severe acute malnutrition. So edema there, it's simply as a result of protein levels. If the protein levels go down, you decrease the oncotic pressure. And if you decrease the oncotic pressure, you favor net flow out of fluid from the vascular compartment. And usually it's going to be bilateral, right? Other functions. So I've talked about oncotic pressure, Then we need it for clotting factors. Remember your clotting cascade, we need fibrinogen, which will stabilize to fibrin meshwork. Then we also need proteins for buffers. They act as buffers in the body. They also act as enzymes, they act as carriers. They have a whole range of functions that you can ascribe to them. Right, so they act as carriers as well. Some of them are hormones. Some of them will act as anti-enzymes, for example, alpha-1 antitrypsin, quite important when you look at the liver, right? So there are a whole lot of functions that you can ascribe to proteins, right? So what really changes protein levels? Right. So whenever you think about a change can either be elevated or reduced. So when you have a raised protein level, what would have happened? For example, maybe this is someone who's dehydrated. If you're dehydrated, that means now you reduce the water, the protein per water volume becomes quite high, so oncotic pressure goes up. You can have some diseases where you have a chronic infection, so you have an increase in gamma globulins. I'll talk about this when you do electrophoresis. Then you can have a decrease maybe in water overload, the pressure goes down, or you have maybe protein loss from maybe a problem in the renal system. We'll talk about nephrotic syndrome in histopathology. Think about skin burns. We've talked about fat embolism syndrome, or you have a protein losing enteropathy in the gut, where you're not absorbing the proteins, but rather you are actually losing them in the gut. Or you can think about the synthesis itself. There's a problem with the liver, you're not synthesizing them. There's a problem in the diet, you're not taking enough. There's a problem in the gut, you're not absorbing enough. That's the malabsorption syndrome that we talked about earlier on in this series of lectures, right? So any of these things can cause protein problems. And the main problem that we talk about, specifically in our setting, is kwashiorkor, right? So this is a diet where protein levels are quite low. Everything else will be high or quite okay, for example, carbohydrates, but protein levels will be low, right? And this will cause edema. The edema is coming from the fact that you have a low oncotic pressure within the blood vessel, right? Then marasmus, on the other end, it's now a defect where, not a defect, but a deficiency where there is both protein and carbohydrates lacking. So these will actually be thin, having thin appearance. The kwashiorkor ones, they may have a thin appearance, but they have a distended abdomen and some form of generalized body edema, right? So albumin is the most important protein, or the highest level protein in terms of concentration. So this we use it to then assess for changes or when we measure it, right? Electrophoresis. So when we do electrophoresis now, remember proteins, they are composed of those amino acids that I talked about at the beginning that are covalently linked by bonds or ionic bonds. So these bonds, they have different affinities, if I may say. for electrons. And so when we do electrophoresis, we can fractionate them into their separate components based on electrical charge. Right. So when you look at an electrophoresis diagram, it will separate them into albumin, the alpha 1 component, the alpha 2 component, the beta component, and the gamma component. Right. So when you look at this now, you see an electrophoresis away from the normal, because the normal should have an elevated albumin. So think about someone who has an abnormal pattern where maybe there is an increase in the gamma globulin component. This shows you that maybe there's a chronic infection happening, leading to an increase in what? In your gamma globulins, your immunoglobulins, right? Or maybe there is some form of multiple myeloma where there is that sharp spike that they talk about, which is being caused by what we call the M protein. Or maybe there is nephrotic syndrome. All proteins are basically lost except the bigger molecules. So you only see maybe the alpha 2 fraction, which is very prominent because it's quite large, right? Then in liver cirrhosis, the gamma globulin component is likely to go up because the liver does not produce your gamma globulins. So this just tells you where you are with the type of pathology that you're having at a given time, right? Then albumin, remember I said it's the most abundant, it's synthesized in the liver, and most of its functions, that's the one that is responsible for that osmotic pressure that we talk about, the oncotic pressure. Then number 2, it's needed for binding. Even when you talk about thyroid hormone, you need albumin for binding. Even when you talk about drugs that you give in, or even cortisol or testosterone, we need albumin for binding. Right? So that's the most important protein that we have. So this can also have abnormal findings, right? So there's what we call albuminemia. This is congenital inheritance where there's just no albumin. So these people will have an edema and altered lipid metabolism. There are other forms of problems with the albumin where maybe it's decreased albumin synthesis, where maybe there is increased catabolism, you're breaking it down, or you're just losing too much of it. Maybe there's a nephrotic syndrome or a protein losing enteropathy. So all the things that I've been talking about, they basically come back to apply to any protein that you have in the body. Right. So what are the consequences of you having low albumin? Edema, number 1. Right. If you have low albumin, remember I said it's a binding protein, you're going to have elevated levels of hormone, which can lead to toxicity. So you can have bilirubin toxicity. You can even think about things like jaundice. So in as much as some of these things we ascribe them to obvious causes from the get-go, you can narrow down. If you then exclude those obvious causes, you now end up with non-obvious causes where you now think about such things like protein, right? Then we also need albumin to measure the corrected calcium level. So when you do calcium metabolism in ChemPath, you're going to talk about albumin where you need it for calculating the corrected calcium level. Also, we need albumin for liver function tests. We have already done liver function tests in this series. I think it was video 3 or 4. Then you also need to assess for kernicterias as well as hydration status. Right. Then, more importantly, if you remember your Ganong, we have what we call acute phase reactants. And most acute phase reactants, these are proteins that alter either by increasing or decreasing in response to an ongoing acute inflammatory process. Right. If you remember your physiology, Ganong had a graph which would show you about 3 of them are actually going down. These are what we call the negative acute phase reactants. These were transthyretin, transferrin, and albumin. These are proteins that are more likely to go down during inflammation. Then the rest of the proteins like your ferritin, your alpha-1 antitrypsin, ceruloplasmin, or haptoglobulin, they go up with inflammation. Right. Then haptoglobulin is an alpha-2, alpha-1 antitrypsin. The name says it itself, it's alpha-1. Then we also talk about complement proteins, which I won't talk about. That should have been done in immunology. Then there is C-reactive protein, which is one of the markers that we measure for an ongoing inflammatory process. Then alpha-2 microglobulin, beta-2 microglobulin. For beta-2 microglobulin, remember, for the purposes of histopathology, this can actually be affected in amyloidosis, and we see this in hemodialysis associated amyloidosis, the beta-2 microglobulin components. It's quite small, and it's part of the major histocompatibility complex. If you remember how you talked about the MHC components in physiology, what's the difference between MHC1 and MHC2 in terms of the components. Right? So all these things, they basically build up. Then ceruloplasmin binds copper. So problems with ceruloplasmin, we talk about Wilson's disease or hepatolenticular degeneration, where now the copper would deposit due to high levels, would deposit in the hepatocytes and cause some problem within the liver. It will also deposit within your lentiform nucleus in the basal ganglia and cause lenticular degeneration. Then it will also deposit around your eye, causing those Kayser-Fleischer rings, which you also talk about when you do liver pathology in histopathology. Right? Then transferrin, of course, is for iron. Problems with transferrin, we have high iron levels leading to more of it being deposited intracellularly as hemosiderin, the iron stores, that is not ferritin, and that can end up with what we call hemosiderosis. Right? So all these things, they have a link to pathology. Right? Immunoglobulins, you can have deficiency. Right? This can be, you've done your introduction to immunology. There is the X-linked gamma globulinemia. I remember this when we went to our immunology exam. There was a question in the practical of a baby who had that, and it was really, really bad. I remember I almost left the whole question. It was a 55-minute exam question, so I think I left it and did the ChemPath section. Right. Then there are other causes of immunoglobulin deficiencies, for example, maybe neoplasias or whatever, right? Or prematurity in itself can cause a reduction in immunoglobulins, right? Then we talk about multiple myeloma, where the light chains are affected, and we see them in urine as unpaired Bence-Jones proteins. You talk about this mostly um, in your hematology, and in histopathology. Remember, you'd say that this will be the 5 to 15% of the people with this multiple myeloma will present with amyloidosis of the AL type, which is the primary amyloidosis that we talk about. Right. Then what else should you know about proteins? Then you can have other conditions which may be beyond me, but this is not just the only thing that you need to know. Amyloidosis falls under this. You need to know because they are proteins. You can have proteinuria now. Remember, we've done urinalysis, so when you now see proteins in urine, this tells you that there is some form of failure in the kidney, maybe in the PCT or at the glomerular membrane, or some form of nephrotic syndrome, even nephritic, though it will be less than 3.5 if you remember, right?